Thanks very much, Dr. Popovich, Dr. Landro, Dr. The Hog, and all of our guests and audience today. What I thought I'd concentrate on today, obviously in 20 minutes, I don't plan to try and tell you everything related to ankle rehabilitation, but I wanted to talk about my second favourite Northern Italian, Vilfredo Pareto, who in 1906 noticed that in his garden 80% of his peas were produced from only 20% of his pods, and at the same time that 80% of the land in Italy was owned by 20% of the Italians. And from this he derived what's since been co-opted and called the Pareto principle, the idea of which is that 80% of what your results are achieved from 20% of what you actually do, or 80% of your income comes from 20% of your clients. And today what I want to talk about is what's the 80% of my outcomes that I think come from 20% of what I do. So I just want to concentrate on that 20%. Now, obviously, that's not to say that we don't do the other 80%. I just want to talk about this, in this case, 3 things that I think give me most of my results for lateral ankle sprain. And those 3 things are listed here: range of motion, strength, and particularly talking about the mechanism, following on from what Dr. Calder was saying. So firstly, ankle dorsiflexion range of motion I think is terribly important, and the way that we measure it is by looking at this knee to wall measure. So the distance that we're after here is this distance, the furthest back, that with the heel still touching the ground and the knee touching the wall, that the big toe is from the wall. And it's important to know that this is quite sport specific. So this is data from here in Qatar. This is about 1,100 footballers' ankles, and these are all of the cyclists in our cycling team. And the footballers are about 11 centimetres on this measure, and our cyclists are 15 centimetres. And this is a little bit chicken and egg. Have you lost, on average, dorsiflexion because you're a footballer and you're constantly beating up your ankle, which the cyclists aren't doing, participating in a straight line sport? But clearly, if I want to get back to this sport versus this sport, I need to know what the sport-specific norms are for this. And what stops you from getting back there, I think significantly, it's this area of soft tissue, which we're going to have talked about a little bit later. So this bit of soft tissue sitting superior to the talus and anterior inferior to the tibia, the triangle of Toll. So there it is just there. Now, obviously we can't change postero-superiorly, postero-inferiorly, but what we can change is the soft tissue just here, or at least, sorry, conservatively, we can't change these things. And the way I try and go about doing this is a couple of different ways. We've co-opted a technique from the surgeons here using the surgical ankle distractor. And what I think's going on here, which allows me to put a lot more force through the ankle, and just pulling straight forwards like this, I can get straight ankle traction. And once I'm sure that the injured athlete, in this case, this is a colleague who's a long-time netball player and has had many ankle sprains. Once you're sure that they can tolerate that, you can make this a little bit tougher by putting a second belt here. And now this is down onto my foot, and so I can at the same time apply a posterior force just through there. And we'll just listen. Can we have the volume? Oh, sorry. Andrea gave me a ringing endorsement there, which I wanted you all to hear, because occasionally you treat a patient correctly. Anyway, so this is a really nice way to try and get more range of motion through there, because the forces that are required to improve this soft tissue just here are just much too high for you to be able to do it with your hands. Now, the second thing is all ankle sprains, and we're just talking about lateral ankle sprains here, all ankle sprains aren't created equal. And I really think you need to treat the mechanism that this athlete turned up with. We'll take a step back with this and talk about first, this is a whole bunch of different data. A lot of people have stood people on trapdoors and then abruptly and unexpectedly dropped the trapdoor away, and then found out how long it took for the perineal muscles to show any activation whatsoever. Now, this is not time to peak force. So this is the time where any activation of the peronei come on. And you see it's somewhere between 50 and 90 milliseconds. So just remember those numbers for a moment. There's been a whole bunch of papers along this line. I'm just choosing this one because the data's nice, but a bunch of different papers have shown the same thing. And I'm also choosing it because I thought it was nice that you could have 6 authors present a case report, which is a good bit of data slicing. Anyway, what these guys doing, they were looking at a sidestepping task, and in particular the kinetics of a sidestepping task. So They were lucky enough to have these guys rigged up with motion capture, and they were landing onto a forced platform. And this poor guy, at the time he landed to then sidestep, sprained his ankle. And as all of these kinematic analyses have shown, that by and large ankle sprains actually happen in dorsiflexion. And this guy got a grade 1 anterior talofibular ligament injury. So what this is showing, because he landed on a forced platform at the time, every thousandth of a second, they were able to say where the centre of pressure was in the foot. So from heel strike here up until a third of a second later at toe off, you could see exactly where the centre of pressure was. And this was the ankle sprain trial, excuse me. Now the ankle sprain itself, the really interesting part is this is the ankle sprain just there. And if we zoom in a little bit more closely on this, the actual ankle sprain here, the data that we've got for it, or the data that these guys showed, I should say, this is the actual ankle sprain. Now, bearing in mind our 50 to 90 milliseconds, the ankle sprain starts here at about 0.09, and it's finished there at about 0.12, so 0.03, about 30 milliseconds, and the foot's coming back into inversion. So there's absolutely no chance for the peronei to be the muscles that are doing this. They just simply can't act fast enough in a feedback mechanism. Now, this is going to be spoken about later by Professor Hurdle, so I'll leave this bit alone. The question that I don't have an answer for that Rold gave me one day is, how does the ankle come back if it isn't active eversion that's doing this, because it's simply too fast for it to happen? How does your foot come back into eversion? I genuinely don't know the answer for that. So what is it? Now, back to what we want to talk about. All ankle sprains aren't equal. I think they can happen a couple of different ways. More often than not, it's landing from a jump. And we can have a couple of different kinds of those. Landing, I think the mistakes that we often make are landing in the wrong spot or the wrong way. And those are the things that we need to look at clinically. We'll just briefly talk about gait, and again, this is going to be presented to you much better by Professor Hurdle later, so I'm not going to talk terribly much about it. Irene Davis's group looked at chronic ankle unstables in sagittal plane gait, so running straight forwards, and she had a group of chronic ankle unstables, people who'd sprained their ankle once and people who'd never sprained their ankle, and they looked at two things. Firstly, where the point of rear foot strike was, either medial or lateral, and it turned out that those people who keep spraining their ankle land a little bit more laterally than those who've sprained it once and never again, and those who've never sprained. But more importantly, the centre of pressure trajectory, once they'd heel strike, so where does their force go, those people who continue to sprain their ankles head substantially more laterally. So not only do they land lateral, their centre of pressure during normal sagittal plane gait is to head a long way laterally. And that kind of makes sense as to why these people would continue to sprain their ankle. And clearly that's something we've got to do about it if these people are spraining their ankle in normal running gait. This has also been shown from some Taiwanese researchers published last year, looking this time at side-to-side movements. So they showed pretty much exactly the same thing, that not only did they land a little more laterally, but their centre of pressure headed further laterally in side-to-side gait as well as straight line gait. Now, if you land incorrectly, why is that such a big deal? Well, research published quite a long time ago shows us that the ankle itself, in the absence of ligaments, if you load it straight through the centre of the ankle axis, is extremely stable just through the bony configuration. And in fact, you can even fracture the malleoli, and if you load it right in the centre, the ankle remains very stable. But these guys who continue to sprain their ankle don't land in the very centre, and that's the problem with them. And so that's what we have to rehabilitate. So the surgeons can fix up the structural abnormalities, but if these people continue to land the wrong way, we're going to continue to load the incorrect structures. Yeah, so that's that point. So I think a lot of this comes down to an inability to accurately put the foot where you want it to go. Either it's going to land in the wrong position, so it physically doesn't go where you want it to go, or it's going to land the wrong way. You land laterally, send your load laterally. We tried to investigate this clinically. Oh, sorry, I'll just take a step back and we'll just look at those different mechanisms of injury first. So this one is a contact injury. So if we watch just here, when you land on somebody else's foot, And I'm beginning to suspect that these ones we probably just can't do anything about. This happens just too fast. So short of changing the rules of the sport to stop people from landing on other people's feet, by the time he's hit that foot, he's effectively driven off the cliff, and no amount of hitting the brakes or turning the steering wheel is going to delay the fact that you're about to crash. So these ones I don't know that we can do terribly much about, and the sport where this happens an awful lot, obviously, is up at the front of the court. Now, we often think that these landing injuries are going to happen in plantar flexion, but again, you watch, if you land by definition, if my forefoot lands on some obstacle, be it a hole in the ground or in this case somebody else's foot, unless my foot's out in front of me, I'm landing in dorsiflexion. So the injuries happen in dorsiflexion. That's where we need to retrain these guys. Now, what made me think about the accuracy of foot placement was a couple of videos I saw, and not being an avid watcher of football, in fact not watching football at all, I just thought these were funny until I thought about them some more, and some people told me that at the time this guy was the best football player in the world. And let's watch both of these incidents. Watch how much his left foot doesn't go where he wants it to go. So in this case, he misses by about 15 centimetres. Now look at that, I was feeling all smug and superior that a PC was beating a Mac, and now the PC's died. Let's just see if we can get that. There you go. Okay, so this guy wants to lift his foot up and over there. That's probably what happened. So you just get two chances to watch this. So his foot wants to go up and over this spot just here, and he misses that completely. And let's just see if we can play this from here. Now, the second time around, at first glance, you think he slips when taking this dead ball, but in fact he doesn't. He just misses completely where his foot goes. You don't see it terribly well there. I did not do that. Now, Cristiano will be able to tell us, and the other decent football players in the audience will be able to tell us in this situation exactly where you want your foot to go. And you see his foot actually lands on the ball itself. So he was trying to place his foot to the side to take that shot, but in fact he just completely missed. His foot didn't go where it wants to go. In this case it's obvious because he's landing and he's knocked the ball out of the way. We'll just jump to there. But by and large, these errors are landing in the wrong position. You don't see that terribly well there, unfortunately. But this girl is landing just on an inverted and dorsiflexed foot. And so by the time she lands on there, she's basically sprained her ankle. She just doesn't know about it yet. The last couple that we'll watch here, this is Kobe Bryant a couple of times. It looks like he's just charging this guy. But you watch there, and he's actually just landing. He's about to sprain his ankle, and for whatever reason, these videos are dying here. So we'll jump to the second one, which hopefully plays a little bit better. So again, on his left foot, now we'll get a better view of it in a moment. Nobody around, and he just lands immediately in inversion. So again, the mistake that he's made is in landing from a jump. He's not landing correctly. He lands on an inverted foot, and that's the thing that we need to manage with this guy. By and large, ask your patients about this, and they might say it's a contact injury because I bumped the other guy, but when you do have the video evidence available for it, go back and look at them. In asking more and more of these people, they'll say that they bump into people or maybe they hit something, but I think it's actually pretty unusual to land on something else, except at the net in volleyball and occasionally in basketball. Now, the one where it can never happen, of course, is tennis. And so again, in dorsiflexion, and this time the load's been shifted too far laterally and perhaps a foot caught on there, and likewise here. So these mechanisms side to side, and you need to be able to land correctly, and so this is what we need to correct in this guy. Now, we tried to investigate this, and I'm presenting you this data in the absolute best light because there's a very good reason we never got to publish this because it was a pretty crappy study. But people who'd never injured their lower limb, when we asked them to try and place their foot accurately, they could do it if we discounted 1 out of 5 of their trials. We let them get one wrong. They could do it to an accuracy of about 1 centimetre. People who had current lower limb injuries, and that's their entire lower limb, this wasn't just ankle sprains, were only accurate to about 5 centimetres or so. And so how we try and trace this clinically is this is a current patient who's got an isolated tear of his anterior inferior tib fib ligament, and the instruction he's been given is to take his big toe and put it exactly there. Now hopefully we'll see how he goes with this. No, missed. Okay, try again. Come back. All right, let me have it. No, missed again. Okay, come over here. Try again. Okay, just step. No, missed again. Come on. Let's try again. Okay, come back, really concentrate this time, and okay, finally I pretty much got it to within a centimetre. So that'd be the drill that we do, either stepping backwards, forwards, side to side, again, depending on what the sport's going to go on. And here I think we need to, is he thinking hard or hardly thinking? When he gets back to sport, he needs to be able to do this hardly thinking, not concentrating as much as he was there. And the landmark paper here was looking at falls in elderly people, published in The Lancet some time ago. And this was a lovely demonstration of the Pareto principle, that there are two classes of old people, it seems, so, which I guess that's me. And so when you're walking along with somebody, if you start talking to them, some older people have to stop and continue the conversation, and then they can keep walking. Whereas other people don't. They can continue to walk when they talk. And just with this simple test, when we looked out to 6 months, the people who are able to continue walking when they were talking, so for them, the cognitive load of just walking isn't that big a deal, less than 20% of them had fallen over in the subsequent 6 months. Those people who couldn't walk without talking, after 6 months, 80% of them had had a fall. So the cognitive load is something that's been investigated by Professor Eric Wittfrau, who published this data last year at ESCA along with his colleagues, and they took a whole bunch of footballers, took a whole bunch of different measures before and after a fatiguing treadmill protocol. They did this pre and post-season, and they looked at ankle sprains, and importantly they adjusted for age and BMI and the incidence of ankle sprains, and the only thing that they found was predictive of getting an ankle injury was your postural control with a cognitive task, so distracting the player. Now it's a very big difference between when I do my task here in rehab as opposed to when he has to go back out onto the pitch and worry about if that guy's going to deliver the ball from over here, or should I be in that position, or hang on, there's two defenders coming towards me, which way should I go? I can't now think about what my ankle's doing. So when we do our balance rehabilitation, we need to try and superimpose a cognitive task so that ultimately the balance can really become incidental. This is just the last thing that they're thinking about. So of course, everybody who sprains their ankle eventually needs to be able to juggle 5 balls at the same time. You probably get all your patients doing the same thing. Now, the last thing I'm going to talk about is strength. Inversion, eversion and dorsiflexion is really easy to measure, but the plantar flexors are just too strong to measure with a handheld dynamometer. So what we did instead here was, with a couple of hundred people, looked at their ability to do this plantar flexion task at the rate of 1 every 2 seconds. You can't see the second hand on the clock there terribly well, but what Beck's trying to do here is maintain that rate of 1 down, 1 up, so 1 every 2 seconds. She's allowed to touch to balance, but later on we actually made people just hold their hand on the side so they couldn't be taking any weight whatsoever. And the trial was stopped when either she said, no, that's it, I can't do any more, or if I noticed that she wasn't going all the way through full dorsiflexion, full plantar flexion, or if she couldn't keep up the time through there. And we just counted that to fatigue, and then she'd end up with a score for a left leg and a right leg. This idea grew out of a throwaway comment made by Craig Purdom, who a long time ago, who'd told me that he never lets people go back to jogging until they can do 20 of these, and he never lets them go back to jumping or sprinting until they can do 25. And why do you do that, Craig? Oh, it just seems to work. And like everything that Craig says, he just kind of knew this already. So here was our data, and we found this lovely normal distribution for how many calf raises these people could do. When we pooled them all together, it averaged around 21 or so. And there was no difference between left and right, but when we looked at the injured versus the uninjured, so these were people who were in the clinic for a shoulder injury, a back pain injury or whatever, this was about 23 versus 17. So what Craig had said, you can't jog until you can do 20 and you can't jump or sprint until you can do 25, has really held up quite well with this. An interesting aside with this is we looked at the frequency of running that all of these people did at the same time as part of their sport. The left and right data was exactly the same. We can fit it better with the polynomial. But what we looked at was people who never ever run up to people who run 5, 6 or 7 times a week. And so interestingly, when we compare these last two groups, the people who run more frequently were less strong. And this has really important implications for our strengthening and for the notion that more physio is better, and go in every day and go in twice a day, and the more often that you do this, well, these people just aren't recovering, and we are actually overtraining these guys. So what should you spend your 20% effort on to get it? Well, I think ankle dorsiflexion range of motion, but don't forget that this is very sport specific. You really need to know how this guy sprained his ankle. Not all ATFL sprains are equal. In fact, I reckon they're all unique. And we need to address the strength. Look and find out what deficit you find. Now, I said Vilfredo Pareto was my second favourite Northern Italian. Who do you think's my favourite? Everybody's favourite Northern Italian, Dr. Iadali. So thank you very much.